Good morning, everyone, and welcome to our second brunch event in our Healthcare Maintenance and IBD series. This series is supported by educational grants from Janssen, Pfizer, and Takeda. I'm Dr. Aline Charabaty. I'm the Assistant Clinical Director of the GI Division at Johns Hopkins School of Medicine and the Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital and the founder of Monday Night IBD. I'm joined today by my very good friend and colleague, Dr. Shannon Chang. Dr. Chang is an associate professor of medicine and is the director of clinical operations at the Inflammatory Bowel Disease Center at NYU Langone Health in New York City. Shannon, good morning.
Good morning, Aline. It's nice to be here. Thanks so much for having me.
I'm very excited that you're here with me this morning, and I'm really looking forward to this discussion. Before we start, these are our faculty disclosure on the screen. The goal for today is really to focus on how important it is to perform specific health maintenance screening in our patients with IBD and to really help us identify which patient needs special consideration when it comes to health maintenance. So let's start. Shannon, why is it important for gastroenterologists to focus on health maintenance for patients with IBD?
This is a great question, and I'm so glad that we're talking about this. What I have noticed and what my colleagues noticed from our practices is that many of our patients are young. They don't have a primary care doctor. We, in all estimations, are their primary care doctor and gastroenterologist. And so it's important for us to address preventative care and healthcare screenings. And even sometimes if the patient does have a primary care doctor, the primary care doctor may not feel as comfortable making recommendations regarding patients on immunosuppression and what the appropriate, let's say, vaccinations or healthcare screenings are. And we know that IBD patients don't always receive preventative services at the same rate as general medical patients. So it's important for us to focus on this, especially when we have time during our visits.
Absolutely. I feel like, as a physician taking care of patients with IBD, we are the internists. We're really taking care of the patient as a whole. We know that IBD affect different organs, but like you said, health maintenance often becomes a responsibility and the expertise of the gastroenterologist. So let's start with what gastroenterologist prefers to do most of the day, which is colonoscopy and colon cancer screening in patients with IBD. And, the traditional teaching has been to screen all our patients who've had disease involvement of more than a third of a segment, whether it's UC or Crohn's, every 1 to 2 years after 7 to 8 years of disease. Of course, patients with PSC are a special population who require colonoscopy once a year at diagnosis. But I was wondering, Shannon, there's so much now discussion about how effective our therapies are at controlling the inflammation, the importance of endoscopic and histological healing, and how we are seeing less colon cancer than traditional historical cohorts. So how can we individualize our colon cancer screening recommendation to our patient? Do all our patients need the same interval? Can we do something about it? Because drinking that prep is never fun.
Right, Aline, I'm sure you and I have the same conversations with our patients, the ones that have been doing so well and, they don't like coming for the colonoscopy screening and particularly the prep itself. We are seeing an ability to individualize a little bit more these days. So in fact, our most recent American College of Gastroenterology guidelines do sort of allow the gastroenterologist to personalize the surveillance intervals from every 1 year to every 3 years, depending on that patient's individual risk factors. Does the patient have a history of pre-existing dysplasia or colon cancer? Does the patient or a strong family history of colon cancer? Does the patient have ongoing severe active inflammation? Those might be patients that you want to screen more on the every 1 or 2 year intervals as opposed to 3. But I think, we have all seen those patients with ulcerative colitis who are doing well. Every time you do their colonoscopy, they're completely healed endoscopically and histologically normalized. Those are the patients that I might space out to every 3 years.
This is great, Shannon. And I think a lot of patients will be happy to know that they don't have to come in every year necessarily. But also it's important to remember as gastroenterologists, this is based on a high quality exam, right? So we need to be using our high def scope. The prep has to be excellent, and we have to take our time with drawing the scope and really examining all the areas to be sure that we didn't miss any lesions, especially when we're considering increasing the interval between colonoscopies. All right, so now up to other organs that we need to keep an eye on in our patients with IBD. Let's start with skin cancer and skin cancer screening. Tell us, what do you recommend to our patient before starting immunosuppressive therapy, whether immunomodulator or biologic, and what do you recommend while they're on these medications or even when they stop these medications?
Yeah, so before we're considering the choice of what type of treatment for our patients, I do usually ask them about a history of skin cancer. I live in New York City, so it may not be as sun prevalent as some other areas of the country, but our patients come from all over, so it's important to ask that question. And for those who are started on immunosuppression, we do recommend that the patients have a total body skin exam with dermatology once a year. Especially this is important in patients over the age of 50 because the risk of skin cancer does increase over the age of 50. Thiopurines in particular increase the risk of non-melanoma skin cancer up to 6-fold. And this risk persists even after stopping the medication. So they have to continue their skin exams annually. And the anti-TNFs, there is a potential increased risk of melanoma up to 2-fold. So those patients, we also emphasize it as an annual exam. But in general, immunosuppressed patients should have a skin exam once a year.
Thank you, Shannon. That's absolutely valuable information. And I think the point you make about continuing to do skin cancer screening even after stopping azathioprine or 6-MP is really important because the effect of these drugs is long lasting. How about with other therapies that we have for inflammatory bowel disease, other biologics, secukinumab, vedolizumab, tofa, ozanimod? Are the recommendations for skin cancer screening the same? Are there any exceptions to these recommendations?
So the current recommendations from the Crohn's and Colitis Foundation, as well as other organizations, do include all the immunomodulators, the biologics we have, with the exception of vedolizumab, and including small molecules such as tofacitinib. So it is recommended for the vast majority of our treatments that these patients still get their annual skin screenings.
Perfect. And absolutely, I always recommend, I'm sure you do the same, wear sunscreen, a hat when you're outside, just protect your skin. I think it's good common sense for everyone, not only for our patients with inflammatory bowel disease. Now let's move to women health maintenance and pap smear in particular, because at some point the recommendation was to do an annual pap smear for anyone on any therapy that could affect the immune system. But I feel that over time, we kind of fine tune those risks and more personalized or individualized how often patients with IBD on immunosuppressive therapy and different therapies require a pap smear, and how should we follow them on the long term. So Shannon, what thoughts do you have on this topic?
So we know that patients with inflammatory bowel disease on immunosuppression are at approximately a 30% increased risk for cervical dysplasia compared to the general population. So for those patients on immunosuppression, the American College of Obstetricians and Gynecologists, as well as the American College of Gastroenterology, recommend annual cervical cancer screenings, pap smears with or without HPV screening for those on immunosuppressive therapy. I would say that, in the younger years, if the patient is not in a monogamous relationship, if there's a history of high-risk HPV strains or a history of ascus or need for colposcopy or concern for cervical dysplasia, those patients are the ones that are higher risk, and we're continuing every year. But it's a gray zone as people get older, they're married, they may not, necessarily have had any abnormal pap smears. I think that's an individualized decision between the patient, their gastroenterologist, and their gynecologist.
Absolutely, I agree. I think for many patients, we probably can move back to a more standard screening. So after a couple of normal pap smear, move to every 3 years if they've been in a stable relationship, HPV negative, etc. So I think the key message here is that health maintenance screening is very important. And then we need to really look at the patient overall picture and history, etc., and try to individualize what we are recommending. We talked a lot, in meetings about pre-therapy screening, and we're all familiar with screening for hepatitis B and TB before starting anti-TNF. But I want to ask you a few things. One is some insurance mandate a TB screening every year, but some don't. So, I want to hear your thoughts about it. Who are the patients that would actually benefit from regular TB screening while on anti-TNF, and who should we just get the first one before starting anti-TNF and forget about it? And then if we can talk about the particular screening that we need to do before ozanimod, our new kid on the block for UC patients, really trying to become more familiar with the pre-test screening with this drug.
In terms of the tuberculosis screening, so I think that this is not something that has come to complete consensus within the GI community regarding immunosuppression. But in general, I think, an annual assessment of risk for tuberculosis is important. So we do ask our patients, it's been a year and a half, 2 years since we checked your quantiferon. Have you traveled to any high risk tuberculosis areas? Are you a healthcare worker? Do you work with the homeless or incarcerated? Any new respiratory symptoms? Those are the patients that I'm going to recheck their tuberculosis screening in order to protect them in the event that they have latent TB developed. In terms of ozanimod, so very exciting new mechanism of action, oral therapy. We're seeing some interesting uptake with patients because of the oral formulation here. It is a little bit different than some of our other medications because it requires an EKG before we start to look for any cardiac rhythm abnormalities. We are avoiding severe bradycardia in those patients before starting and screening for that. In addition, something interesting on the label is that varicella zoster IgG has to be checked, and if the patient is not already immune either through childhood exposures or through vaccination, then they should get their vaccine for varicella before they start the therapy, generally at least 1 month ahead of time. And then also questions to ask clinically to the patient. Do you have a history of macular edema, uveitis, or a history of diabetes? Those patients may not be optimal for this type of treatment, and they may need to see an ophthalmologist ahead of time.
This is very important to become familiar with. And I think the good news is that the maker of ozanimod really facilitate performing these tests for the patient and make it easy. It's just, a new pre-medication testing that we need to become familiar with. Patient often ask, what can I do to prevent progression of the disease, what I eat, physical activity, etc. But one of the most important things for our patient with Crohn's disease is really smoking cessation. This has been the environmental factor that has seemed to have the most impact on Crohn's disease progression. Can you tell us about this? And do patients need to stop completely? We all know how much smoking cessation is difficult. Would even decrease in the number of cigarettes make a difference? And why does smoking affect Crohn's disease? Like, what does it do, and why is it important to have that discussion with our patients?
Right. So smoking is in general not good for our health. And the cumulative pack years, the increased amount has been linked to development of cancer, pulmonary disease long-term, as well as just, in Crohn's disease, we see that smoking increases the risk of development of Crohn's disease, as well as after you have the diagnosis of Crohn's disease, an increased risk of surgery or repeat surgery or non-response to therapy or need for step-up therapy. So smoking is really a no-no in Crohn's disease. And in terms of how much smoking. I'm really aiming high here and asking for complete smoking cessation. But, I think it is a tough thing to ask someone to go from 60 to 0 in this situation. So I do every check-in with the patient, ask them at the very end during my screenings, how's the smoking cessation going? We do try to set goals. Maybe, if you're at a pack, half a pack by the next time I see you, and then complete cessation after that. It is a tough thing to quit for a lot of our patients. But I think that if you discuss with them the reasons that you're so focused on smoking, a lot of them do comply.
Absolutely, I agree. It's all about communication, right? And addressing the importance of how these measures improve the quality of life and the health of our patients with IBD. We're treating their GI illness, but also we want to prevent other complications either related to their inflammatory bowel disease or the therapy that they are receiving. Absolutely, communication is crucial. And talking about communication, I just want to let everybody know we'll be focusing on mental health screening and mental health therapies in patients with IBD in another brunch. But Shannon, thank you so much for joining me today. I learned so much with you always, and particularly this morning. For everyone who tuned in, thank you for joining us today. Don't forget to check out our tutorial tomorrow under Monday Night IBD that will complement the discussion we had today. And make sure to claim your CME credits by completing the post-test and evaluation in the link above. And remember, we'll have additional brunch events in March, in the spring, that will also focus on health maintenance and IBD. Have a great day, everyone. Shannon, thank you so much.
Thank you so much. It was a pleasure.